without any interruptions. But now I realize I'm actually presenting to seniors more than I'm presenting to juniors. Suddenly I'm going back 10 years and it feels like I'm doing my MCH Viva all over again. I'm Dr. Sai Surabhi. I'm an associate printed and a few take-home points. This is the mitral valve apparatus. The mitral valve apparatus includes 5 important structures: the mitral annulus, the mitral leaflets, the anterior and the posterior leaflets, the caudate tendae, the papillary muscles, and the left ventricle. Again, not going into the details of the blood supply and what are the anterior leaflets and the posterior leaflets and the primary and secondary and tertiary chordae. This is the surgical anatomy of the mitral valve. This is a cut section of the mitral valve. That is how the mitral valve is seen when we see it from the base of the heart. There are scallops that are seen in the posterior segment. This is the from lateral to medial. There are P1, P2 and P3, and the corresponding segments are A1, A2 and A3. This is the entire mitral annulus, and these are the very important surrounding structures which I'll be coming to in my next slides. This is a very important slide that I'll take a little extra time on. We shall consider the mitral valve as a circular structure which represents a clock. Right opposite the surgeon's side, this is the 12 o'clock. That is the mid part of the A2 segment, and the mid part of the P2 segment becomes the 6 o'clock, and then perpendicular to that is the 9 o'clock and the 3 o'clock. So corresponding to the positions of the clock, what are the most important landmarks that are both visible and invisible to us as cardiac surgeons? Firstly, the most dreaded and the most feared, the left circumflex artery. It courses posteriorly from the 11 o'clock till probably the 8 o'clock position. Next comes the coronary sinus, which courses posteriorly from the 4 o'clock till the 9 o'clock position. Besides this, other important structures are the left coronary sinus and the non-coronary sinus, and the aorta mitral curtain, which is from the 11 o'clock to the 1 o'clock position. Besides this, between the 10 o'clock and 11 o'clock positions and the 1 o'clock positions, we have the left fibrous trigone and the right fibrous trigone. The commissures of the mitral valve are at 10 o'clock position and at 2 o'clock position. These are the structures which are again invisible. At about 10 o'clock position, we have the atrioventricular node, which is important for us because in case of a bite near the intraventricular node or a deep injury to this, we can cause an AV block. The different approaches to the mitral valve. After reviewing anatomy, there are almost 15 approaches to the mitral valve, including minimally invasive and robotic techniques. Firstly, approach to the heart. We have a standard median sternotomy. We have the standard median sternotomy and the hemisternotomy. Besides this, we have other approaches. This is a C-shaped sternotomy in which the manubrium is spared. The L-shaped sternotomy, the lateral L-shaped sternotomy, incision at the 4th intercostal space, incision at the 5th intercostal space. These two are the right anterolateral thoracotomy incisions which are used in minimally invasive mitral valve surgery. This is the incision which is parallel to the sternum, which helps for again minimally invasive, and this is the upper mid hemisternotomy for minimally invasive mitral valve replacement. The cannulation techniques are standard aortic and bicaval cannulations. Why bicaval cannulation? Whenever we are approaching the mitral valve, there are two important structures that we encounter. Firstly, whenever we are opening the RA, we do not want any air embolism, because of which we have to do a separate cannulation of the SVC and IVC. Secondly, whenever we are retracting the LA, it so happens that if there is a straight cannula that can impede returns of the heart and the systemic circulation to the cardiopulmonary bypass, and we'll have our perfusion colleagues keep on saying, well, volume is dropping, please give us volume. Because of that, we do a bicaval cannulation. Again, SVC can be cannulated directly to the SVC, or from the RA appendage, a cannula can be inserted into the SVC. Snugging, no snugging is again a surgeon's preference. This is the first incision, which is vertical left atriotomy. As soon as the aorta is cross-clamped and the CP is given, the first thing that we have to see to it is that the LV is not distending. For that, we need to vent the LV, and that is where we put an incision in the right superior pulmonary vein. The left vertical atriotomy is the most common incision that is used, and that is generally between the two pulmonary veins, that is the right superior and the right inferior pulmonary veins. Once we have opened the mitral valve, what we need open the LA, what we need to realize is we do not put in a retractor into the LA till the cardioplegia is over. Why? As we have already seen in the anatomy, once we retract the heart, we have the non-coronary and the left coronary cusp. So once we retract the heart, it so happens that we can distort the aortic root and the aortic annulus, because of which the cardioplegia or the myocardial protection may be inadequate. These are most common retractors that we use for retracting or exposure of the mitral valve. The most common Cooley's retractor. This is the Bonchek's modification of the Carpentier retractor. Then we have the self-retaining Cosgrove mitral retractor, which has 3 mini Cooley retractors attached to it, which helps in retraction of the mitral valve. Besides these are alternative retractors which are used probably for general cardiac surgery, not specific to mitral surgery. We can use the Langenbach's retractor, we can use the Ross's aortic retractor, and sometimes even 2 VSD retractors in cases of small left atrium. This is the second incision. This is the incision which Sir has described in the morning when he was describing the anatomy. The Sonnegart's groove is the groove between the LA, and the array. It is a fat plate. This is a fat plane. The incision to the Sonnegart's groove is about 1 to 2 centimeters parallel to the incision of the left atriotomy. We have to dissect this. People generally prefer this because it gives adequate or much better exposure to the mitral valve. However, the disadvantages to this are there is a lot of fat plane that is here, so there can be microembolization of the fat into the left atrium, and secondly the left atrium is thinner in this position, so suturing should be much more meticulous, and thirdly because it is between the LA and the RA, we may sometimes inadvertently open the right atrium. This is transection of SVC, probably a little more barbaric, but another way is to extend the incision of the left atriotomy superiorly into the left atrial roof. In some situations we can transect the SVC, however, nowadays we don't have to. Adequate mobilization of the SVC below the right pulmonary artery and between the right pulmonary artery and the right superior pulmonary vein gives us adequate access to approach the roof of the LA and extend the incision to the roof of the LA. This is the transseptal approach. This is something what I have labeled as an unplanned transseptal approach, in which we have opened the left atrium using the left atrial vertical incision, and then we have realized that the exposure is not adequate and we are not able to visualize this. In that situation, what we can do is we can open the right atrium and then open the interatrial septum along the fossa ovalis to have a better and a fuller and a more straightforward approach to the mitral valve. However, in this we need to be careful not to extend the incision more inferiorly, because that is where we get the coronary sinus, and injury to the coronary sinus can be more problematic. This is again self-labeled a planned transseptal approach, in which we have decided before only that we will not be opening the left atrium. So we open the right atrium parallel to the AV groove, and then vertical incision over the fossa ovalis to enter the left atrium. This is the Dubos transatrial approach, in which a horizontal incision is given all along the right atrium across the Sondergaard's groove into the right superior pulmonary vein. This opens the and the incision is extended vertically into the fossa ovalis to open the right atrium and the left atrium to expose the mitral valve. This is a superior septal approach. The superior septal approach take the incision from the right atrium. It goes superiorly above the right atrial appendage into the near the non-coronary cusp of the aortic valve. However, the problems with this incision is the fact that the right coronary artery arises and the node to the sinoatrial, the artery to the sinoatrial node arises around here, and in 30% of the cases there can be injury to the sinoatrial node, because of which there can be postoperative AV blocks and dysarrhythmias. This is an incision that is probably most commonly used in pediatrics and neonatal patients, wherein the approach to the left atrium is much more easy because of the supple structures of the aortic, the aorta and the SVC. This is the LA roof that is present below the that is bordered by the aorta, the right pulmonary artery and the SVC. This is the trans-aortic approach. Again, I am mentioning this only for exam purposes. I've tried to visualize myself to do this trans-aortic approach, and I'm really not sure how we can access the PML in the trans-aortic approach, because when we open the aorta, definitely we tend to see the anterior mitral leaflet, but the posterior mitral leaflet is definitely out of at least my eyes. The left ventricular approach is generally seen in patients in whom we have a post-myocardial LV aneurysm repair or an LV free wall rupture, or in these patients we put an incision parallel to the LAD and go through the infarcted segment, and we see the inferior surface of the mitral valve. It is in this view that we get to see the papillary muscles, the caudate tendineae and the entire mitral apparatus. Again, historical importance. Another approach to the mitral valve is through the closed mitral valvotomy. The closed mitral valvotomy is through an incision in the fourth or the fifth intercostal space on the left side, and we have a bursting suture on the LA appendage and another bursting suture on the left left ventricular apex. The Tubbs dilator is passed through the left ventricular incision, and the the surgeon's index finger guides the Tubbs dilator through the mitral valve using the left atrial appendage incision. Again, this is in case we have to convert a closed mitral valvotomy into an open mitral valvotomy. In this situation, the cannulation techniques goes that we can cannulate the femoral artery or the descending thoracic aorta, and venous drainage can be done by the pulmonary artery, which is right beside the LA appendage. This is probably another one of historical importance. This is the autotransplantation procedure, or also called the bench procedure, in which the entire heart is explanted from the patient and it is kept in ice solution, and the mitral valve is repaired and it is kept back into the patient after repair. This takes this has been done by Norman Shumway when he initially was experimenting on heart transplantation. Besides this, there's one more thing, is the robotic technique, which is another approach to the mitral valve. How do I do a mitral valve replacement? My plan for a mitral valve replacement starts right from seeing the patient. I examine the patient, check the ECG, see if there's any left atrial enlargement, check the chest X-ray, look at the size of the heart, check the 2D echo, know the size of the heart, whether I'm operating on a stenosis or a regurgitation lesion. Like I said, this is a surgical conference. I'm not touching on the theory. I'm just giving practical points on how to do the entire surgery. Standard midline sternotomy is what to do. However, Jacob sir in one of his conferences said that probably the sternotomy about 1 to 2 millimeters to the right would actually help us access the left side of the heart easier, the right side of the heart easier than the left. we do an inverted T-shaped pericardiectomy, and the stays are more on the right side and on the left. That is, the left side of the pericardium is stayed and lifted up, and the right side is stayed and lifted up, and the left is left free, because we do not want the left apex to be lifted up. If the apex of the heart is lifted up, the mitral valve apparatus goes away from the surgeon's view, and it is a difficult visualization again. Cannulation is again ascending aortic bicaval venous cannulation. Cardioplegia is a root CP. The solutions we use are either Delnido or St. Thomas solutions, and LV venting is through the RSPV. Okay, once the mitral valve has been exposed using the Cooley's LA retractor, this is what we look at. In this patient, in order to improve exposure, there are a few things that we can do. Firstly, get the table slightly up and away from the surgeon by about 15 degrees. Then secondly, have adequate lighting, preferably headlight, or adjust your OT lights so that you can see the entire LA through a tunnel. What do we see? Whenever we open any structure, whenever we open the heart, we always first need to inspect what we are doing and where we're doing. So what all we need to see? We need to identify the pulmonary veins, if there's any LA appendage or LA clot, and we need to inspect the mitral valve apparatus as a whole. In this case, this is one of those rare cases in which I could see the entire pulmonary veins and the left atrial appendage, the mitral valve. Why is this picture important is that this is the only thing that a surgeon can see. All other important structures, the left circumflex artery, the coronary sinus, the left trigone, the right trigone, the supposed iotomitral curtain, the non-coronary cusp, and even the AV node, these are all not visible to the eye. We just have a very approximated view of this probably is here along these lines. But this is what we actually see. In this patient, this was the calcified mitral valve. Just superior to the calcified mitral valve is the left atrial appendage. This is an exam question. What is the superior structure to the mitral valve is the left atrial appendage, and what is posterior is the left superior pulmonary vein and the left inferior pulmonary vein. So once we have inspected the entire anatomy, I generally prefer ligating the LA appendage before I, in around 80 to 90% of the cases, depending upon the size of the LA, I prefer ligating the LA appendage before I excise the valve also, because in the next slide I'll show you how close the LA appendage can be to the mitral annulus. In case of a mitral regurgitation, if there is a chance of saving the entire mitral apparatus, I directly start taking sutures. Otherwise, most commonly we use a forceps or we use a mitral hook, lift the anterior mitral chordae and examine the anterior mitral valve. An incision is placed exactly at the A2 segment, and once from the A2 segment, the incision is extended first anti-clockwise and then clockwise. Then after that, depending again on the surgeon's perspective, once the anterior mitral leaflet is partially excised, we can start taking sutures from the 12 o'clock position, and using the leaflet as a traction, we can keep taking sutures all along the mitral annulus. This is another important technique that we follow in our institute when we have to excise the chordae. Please remember, this is the red zone and this is the white zone. And always remember, no matter where we are, no matter what we do, we have to be in the white zone, because entering the red zone can be detrimental both for the patient and for the surgeon. These are the chordae tendineae. We use a right angle forceps and cut it on the white zone so as to not injure the deeper structures or the papillary muscles. This is the picture showing the excised mitral valve. I'd like to actually point out that this was the LA appendage, and this was how close the LA appendage is to the mitral annulus. Hence, once a valve is placed, if we want to do an LA appendage ligation, it can be a little more tricky than before. Yeah. Now, what is the suture that we use? we use a 2O 26 mm half circle double armed round bodied taper cutting needle with a PTFE 6 mm pleated suture which is 75 centimeters long, which is green and white color coated braided non-absorbable polyester. We like I said, this is just one of the steps. We can do it either with or without valve excision. We can either start at the 12 o'clock position or the 6 o'clock position. We can use the forehand technique or the backhand technique. Generally, I use the backhand technique to start from the 6 o'clock till the 3 o'clock position and then start using a forehand technique. And again, from the 6 o'clock position to the 9 o'clock position, I use a backhand technique. We use a suture guide. We use the seated suture as a guide to take the next bite, and the pledges are generally on the LA side. This is the picture which shows the saddle-shaped mitral annulus with the sutures in situ. The valve sizing is generally using the standard company sizer, and it is matched to the mitral annulus. Generally, classical teaching teaches us that we use one size less than that is to the mitral annulus. And why do we do that? If we actually go back to the physiology, we know that the mitral valve and the mitral annulus is a saddle-shaped structure. Hence, when the LV is contracting, it moves in a three-dimensional way. So if we put in a mitral valve that is exactly fit, there may be some disruption and there may be some tension between the contraction of the LV and the mitral valve, which can, there are chances it can cause AV disruption. So that is why we generally tend to size it one size less. And then otherwise, another thing that we generally tend to follow is to correspond to the patient's body surface area. These are the suture guides that I was talking about, which helps us in placement of the sutures and helping guiding to the next suture. How do we place the mitral valve? The mitral valve is generally placed perpendicular to its original bileaflet position. Why do we do that? Firstly, in case of a total caudal preservation, placing the mitral valve perpendicular to the structures gives us, it does not cause any LVOT obstruction, and secondly, it provides us with better hemodynamics. This is how do we tie the sutures. As a rule, we start at 12 o'clock. As a rule, it can be tied in any way. There's no rule in that. That is probably the rule. But how do I do it? I tie sutures at the 12 o'clock position, at the 6 o'clock position, at 9 o'clock position, at 3 o'clock position, and then tie the, I seat the valve and I fix it in that position and then tie all the remaining sutures. Always, once the valve is seated, before we remove the knots, please check for the movement of the valves to see that no submitral apparatus is causing any obstruction to the opening and closing of the valve. LA closure is done using a 3O polypropylene suture, which is a 26 mm needle, and we generally use two sutures. We have to see to it that both the edges of the LA are properly incorporated and under vision, and even the endothelium of the LA is taken. De-airing the LA and the LV can be done in multiple ways. Firstly, agitating the mitral valve by using a Foley's catheter, or we can use a forceps to keep the LA open, or fill the LA and the LV with saline before closing the LA appendage. Then, before we close the last suture of the mitral valve, ask your anesthesia colleagues to start ventilation, ask your perfusion colleagues to fill the heart, put the patient in a Trendelenburg position so as to prevent air embolism. At no point after a mitral valve replacement do I squeeze the heart. I do not touch the LV or the RA whenever I have put in a mitral valve. Declamp the root and then do a root vent. Once the heart starts beating, that is when I finally close the LA and close the second suture. How much time do I have? I have 10 more slides. Okay. A few special situations. How do we approach the mitral valve in case of a double valve replacement? That is like an aortic valve and a mitral valve. What do we do in case of a mitral valve with a tricuspid valve? The tricuspid valve can be managed before cardioplegia on a beating heart, after cardioplegia on an arrested heart with LV venting, after the mitral valve replacement and plus or minus the LA closure on an arrested heart, or it can be managed after closing the LA, unclamping the heart, and just as heart starts to beat. What about in a patient who requires a cardiopulmonary bypass with a mitral valve replacement? Always give importance to doing the distal anastomosis first. Why? Firstly, the mere fact that we are doing a CABG means this patient has a compromised myocardium. So whatever CP we give, the myocardium is kind of compromised. So we want to do a CABG. We want to give him additional myocardial protection if required. We even finish the Lima LAD anastomosis. Once we check the anastomosis for no leaks, we can go back and clip the leak. I just talked about mitral Yes. There are multiple techniques.
I had forgotten, but if you insufflate CO
cylinders for it. But then somehow we stopped. I don't know why.
yeah, it's mostly
I've been using. Never had any all those. It's a good thing.
And all. This might be a relatively benign option in a way.
One more doubt which I might say that the option of putting a larger supra and annular valve compared to an intra-annular
No, I think you only said it. Do keep it simple. Do, don't be a hero. You've said it. So I think what is a comfortable fit. I think each one of us gets trained and we by one size. If you put the plug jets from the LV side, you can put in a bigger sized valve. So these are the things you can think of in terms if you're planning this thing. So again, there is no point in being a hero. But the other point is we have to keep in mind there is a patient processes mismatch in the mitral position as well. So for a very large patient, if you're putting a 25 valve or even lesser, then you need to think about how to get out of that situation.